We're going to go on to Dr. Matthias Maiwald. Dr. Maiwald is a senior consultant and head of service microbiology at KK Women's and Children's Hospital and an adjunct associate professor at Department of Microbiology and Immunology, the National University of Singapore, and at Duke NUS Graduate Medical School. He graduated with an MD from the University of Heidelberg, Germany. He has previously worked at the University of Heidelberg, at Stanford University, and at Flinders University in Adelaide, Australia. He holds a German board certification in medical microbiology, a fellowship of the Royal College of Pathologists of Australasia, and is a diplomate of the American Board of Medical Microbiology. He has three main areas of interest: microbiological aspects relevant to women's and children's health, molecular detection and characterization of fastidious and emerging pathogens, and infection control with an emphasis on hand hygiene and skin antisepsis. He has a publication record of more than 120 articles, including journal articles and medical textbook chapters. Thank you, Dr. Maiwald, and please give your presentation at this time.
Thank you so much for the kind introduction. I will talk about the unusual re-emergence of respiratory pathogens after lifting of the COVID-19 restrictions in Singapore. Singapore has a history. It has been badly hit by the 2003 SARS outbreak, and that included 33 deaths in Singapore, including 5 deaths among healthcare workers. Singapore then learned the painful lesson. Due to its exposed location as a trade and travel hub, Singapore is extremely vulnerable to imported infections, and a lot of preparation went into the time in between 2003 SARS and the COVID era. So let's look at the pandemic response measures in Singapore during the COVID pandemic. In February 2020, the outbreak response level was raised to orange. It's called DORSCON orange. Then in April 2020, there was a complete lockdown, the so-called circuit breaker. Starting from June 2020, there was a phased reopening very cautiously. Safe distancing measures remained in place. Masks outside the home remained compulsory. And then starting from 2021, there was further reopening, a loosening of measures. But for example, mask wearing and safe distancing measures remained in place. Then during 2021, there was a heightened alert because of an increased number of COVID cases. And for example, healthcare staff had routine rostered testing, meaning they were periodically tested for COVID. Then September, October 2021 had a stabilization wave, but also at the same time, the Delta wave hit. And again, a tightening of measures happened. In 2021, there was a transition phase. It continued from 2021. Further easing of measures happened. And in April 2022, the outbreak response level was lightened from orange to yellow with a further relaxation of measures. And then in October 2022, there was a transition phase to resilience, with mandatory mask wearing only for healthcare facilities and public transport. And in February 2023, the outbreak response was lightened to DORSCON green, meaning that's the normal outbreak response level. Mask wearing was only mandatory in healthcare facilities with patient contact, and all other restrictions were lifted. So in summary, Singapore, during the COVID pandemic, went through a series of measures. Initially, a complete lockdown, then phased reopening, subsequently tightened measures depending on the situation, and then a final reopening in February 2023. So we are a microbiology service, clinical microbiology service at the Women's and Children's Hospital in Singapore. And we use for our respiratory pathogens testing the BioFire Film Array 2.1 multiplex PCR. It is a rapid multiplex PCR with 19 pathogens, And COVID, it takes about 45 minutes. And here are the pictures. And we had an initial publication about this together with colleagues from other hospitals. And what you can see on the slide is on the left part of the slide, you see 2019 before the pandemic. So the viruses go up and down. The red virus is influenza A. So what you can see is that towards the end of 2019 and the beginning of 2020, influenza A had a big peak and we had lots of cases. And then subsequently in 2020, the measures set in, initially travel restrictions and others. And you can see the influenza viruses A and B disappeared first. And then subsequently, around April, there was a near complete disappearance of all respiratory viruses. And then subsequently, towards the end of 2020, enterovirus, rhinovirus reappears. And then also the green line on the bottom of the slide, right bottom of the slide, adenovirus also reappears, although at a relatively low level. So other countries saw similar trends occurring. In Australia, there was a marked decline of other respiratory viruses among the measures. Then in the US, there was much less influenza activity. You see the red arrows on the top right side of the slide. Similar things happened in the Middle East, the paper towards the right lower end of the slide. And similar things also happened in Europe. On the bottom left part of the slide is a paper from Italy with the absence of other respiratory viruses during 2020, like RSV and flu. But then the question arises, what happens thereafter? What comes after the initial disappearance of the respiratory viruses due to the measures? In Australia, on the left part of the slide, there were off-season RSV epidemics after easing of the COVID restrictions. Similar things were observed in Europe. On the top right part of the slide, you see the blue line with a red arrow pointed out. Similar things were also seen in Japan, and similar things were seen in other countries. So in this slide, we show on the left part of the slide an unusual resurgence of human metapneumovirus in Western Australia. On the right part of the slide, you see the Australian influenza surveillance report with a much higher than usual peak of influenza in 2022. And in the bottom part of the slide, right bottom part, you see that children in Germany had relatively high numbers of RSV. It rose sharply from October 2021 and overwhelmed Children's Hospital. And children in Germany hospitalized with RSV, the numbers were about 6 to 8 times higher than those with COVID-19. And in Singapore, in 2022, we saw influenza A and B cases rising about mid-year. RSV surged early to mid-2021 and 2022. And in 2022, we saw hand-foot-mouth disease coming back again to Singapore, and enterovirus meningitis cases reappeared in Singapore. So here on this slide, I show you the percentages of respiratory viruses 2019 to 2020. So what you see on the top part of the slide is 2019. The red part is influenza A. It usually has two peaks in Singapore. Singapore being tropical gets some influenza from northern hemisphere peak and also from the southern hemisphere winter peak. Then if you look at the green line, RSV usually has mid-year peaks, and the orange line, adenovirus, usually has no pronounced peaks. And then the pink line, enterovirus, rhinovirus, probably more rhinovirus, but the assay doesn't distinguish it, hovers around all year. And again, as I showed you in the previous slide, in late 2019, early 2020, we saw a huge influenza A peak. So then if we look to 2020, after the pandemic alert level orange came in, we saw disappearance of influenza first, and then around April, when there was a hard lockdown, other viruses disappeared. And then towards the end of 2020, after a cautious reopening, first enterovirus, rhinovirus, then adenovirus reappeared. And the interesting thing is that enterovirus, rhinovirus, and adenovirus are non-enveloped viruses, meaning they are more hardy in the environment. And the reopening happened still with mandatory mask wearing, but increasing social contacts, which prompts us to hypothesize a role of contact transmission in this setting. So let's look at 2021 and 2022. On the top part of the slide is 2021. We see a pre-seasonal RSV peak with numbers much higher than pre-pandemic. Then around May 2021, there was a big number of COVID cases coming to Singapore. The restrictions were heightened again around May, and many of the viruses went down again in response to the additional restrictions. And then towards the end of 2021, there were another set of heightened restrictions, and some viruses again went down. And what we see with the pink line, enterovirus, rhinovirus, is a virus that's relatively prevalent. It hovers up and down and hangs around at levels greater than pre-pandemic. So then let's look at 2022 on the bottom part. Enterovirus, rhinovirus hovers up and down again. Then if we look at the green line, RSV, there is a peak that is in season now, or near to in season, but higher than pre-pandemic. And if you look at the right part of the bottom part of the slide, you see that influenza A starts reappearing, presumably from the southern hemisphere. That is the red line in the slide. And late 2022 also saw an unusual metapneumovirus peak appearing. So if we look at 2023 and 2024, in early 2023, in February, nearly all restrictions were lifted. What we saw was a big adenovirus surge. We also saw RSV numbers up in the first half of 2023. And again, enterovirus, rhinovirus hovers up and around. And influenza A, we saw quite regularly again. And if we look at 2024, influenza A looks like it is returning to two peaks as pre-pandemic. RSV is getting closer again to its pre-pandemic mid-year peak, and enterovirus, rhinovirus hovers around again at about pre-pandemic levels. And 2025, for 2025, logically, I only have the half-year data. Influenza A has a northern hemisphere peak, enterovirus, rhinovirus hovers around, and RSV appears to return to its mid-year peak. So virus patterns in 2025 appear to be returning to near pre-pandemic levels. That includes an influenza A northern hemisphere winter peak, and it includes an RSV mid-year peak. So in summary, at our hospital, we tested around 120,000 samples between 2019 and June 2025, and 90% of these are pediatric patients approximately. The respiratory viruses followed COVID-related restrictions, but not all in the same way. Enterovirus and rhinovirus and adenovirus returned first. Both are non-enveloped viruses. At an increasing social contacts with still mandatory mask wearing, which suggests a partial role of contact transmissions. Subsequent heightened or lower restrictions were followed by viruses going up and down accordingly. Some countries had RSV peaks that strained children's hospitals in late 2020, and Singapore had that in early 2021. And several viruses, for example, Adenovirus and Metapneumovirus, had unusual phases of high activity, and that was much higher than pre-pandemic. Influenza A returned in the second half of 2022, probably from the southern hemisphere, and enterovirus, rhinovirus overall were the commonest viruses. They kept hovering up and down, and in 2021 to 2023, they were there at greater than pre-pandemic levels, and 2024 and 2025 again near the pre-pandemic levels. Let's also look at the percentages of respiratory bacteria in this slide. In 2019, pre-pandemic, if we look at chlamydia pneumoniae, we usually have very few cases, less than 5 a year, so that's not an important bacterium here. Bordetella pertussis, we see about 20 to 30 cases a year. Bordetella pertussis, usually about 50 cases a year, and Mycoplasma pneumoniae, about 300 to 400 cases a year. But then again, if we look at 2020, many respiratory bacteria nearly completely disappear. And then if we look at the bottom of the slide, I'm actually not showing the data for 2021 and 2022. There was a near absence of respiratory bacteria. So in 2023, what we saw was a return of Bordetella pertussis at levels greater than pre-pandemic. Mycoplasma pneumoniae resurges, which was associated with outbreaks of pneumonia in China. And if we look at 2024, Mycoplasma pneumoniae rises to its highest levels ever seen in Singapore, but again, nowhere near the greater than 50% levels seen in late 2023 in China. And in 2025, we seem to see a stabilization of the issue. Mycoplasma pneumoniae is present, but not at the levels seen in 2024. And Bordetella pertussis remains near absent. So here's the summary of respiratory bacteria 2019 to 2025. The bacteria disappeared similarly to viruses in the early pandemic. In 2021 and 2022, we saw a near absence of respiratory bacteria. Mycoplasma pneumoniae remained near absent until April 2023, which is a very prolonged phase of absence of Mycoplasma pneumoniae. But then late 2023 saw a big Mycoplasma pneumoniae resurgence, also huge case numbers in China. And in mainland China, there was a greater than 50% percentage of all specimens positive for Mycoplasma pneumoniae in some centers, and that was associated with greater than 90% genotypic macrolide resistant. So that is huge. Bordetella pertussis remained near absence throughout, and Bordetella pertussis returned around March 2023 in greater numbers than pre-pandemic, but the trend did not continue in 2024 and 2025. Anecdotally, Singapore saw a slight uptick in invasive pneumococcal disease in late 2024. Those data are not shown. And again, here on this slide, we show that similar trends as for viruses are seen in respiratory bacteria. On the right part of the slide, you see Singapore with the respiratory bacteria, in this case Mycoplasma pneumoniae, and the gray zone on the slide shows the near absence of these organisms during the lockdown measures. And this is a collaboration work between a Swiss and British group and us, and they include worldwide collaborators on the Mycoplasma pneumoniae prevalence data. And again, as I summarized in the previous slides, Mycoplasma pneumoniae remained absent until about the first half of 2023. But then if you look at this slide, in late 2023, Mycoplasma pneumoniae made a resurgence or re-emergence. In quite a number of countries, it came back. And if you look at the right part of the slide, it had a big surge of cases in China, where in some of the centers in China, greater than 50% of all respiratory pathogens tests were positive for Mycoplasma pneumoniae, and it was dominated by few epidemic clones with high percentages of macrolide resistance. And it was also caught by the press as a wave of mysterious childhood pneumonia. So here in this slide, we show subsequent to 2023, what was happening. Again, on the left part of the slide, it shows one paper where we collaborated with a Swiss and British group on Mycoplasma prevalences. And if you look at the situation in China, you see huge resurgence in late 2023 with greater than 50% of samples being positive. This is mirrored, but at much lower rates in Singapore, which is on the bottom left part of the slide. And similarly, in China, there was a resurgence and atypical clinical patterns of pertussis observed. And in top right part of the slide, you see a summary of Mycoplasma pneumoniae findings, whereby the manifestations were not more severe than before the pandemic, but increasing mucocutaneous manifestations were seen. So here is a summary of the observed phenomena. The COVID-19 pandemic restrictions were associated with a broad decline of many respiratory pathogens. Loosening or lifting of restrictions was associated with pathogen return. The effects of control measures and relaxation varied between pathogens and phases, and pathogens did not return all at once, but they had unusual patterns. So for example, RSV had early out of season peaks, Influenza A returned late, and presumably the Influenza B Yamagata lineage likely went completely extinct worldwide, while the Influenza B Victoria lineage and Flu A returned. Several viruses returned to greater than pre-pandemic levels. Pertussis in Singapore remains near absent, and parapertussis had a greater than pre-pandemic surge. Mycoplasma pneumoniae returned after a long hiatus with a big surge in mainland China. So what may have happened? And here are some papers that speculate that an immunity debt may have arisen. So I will cover that in some of the next slides. So what is the concept of the immunity debt as it was proposed here? It says that children who were born and or raised from young were not exposed to many pathogens during the COVID-19 pandemic restrictions. Those children are now non-immune to many pathogens, and the consequence is a more frequent infection and more infections at an older than usual age. But skepticism was also expressed on the bottom of the slide. Does it really exist? So there was some discussion arising. And here I'm putting up some competing hypotheses, what might explain these issues that we observed. So the hypothesis one is a simple lack of exposure and a lack of specific immunity. This was seen in 1846 on the Faroe Islands, which is a very remote group of islands that belongs to Denmark. And measles had not been seen for greater than 60 years, and no one less than 60 years old had immunity. And over a 5-month period, 6,100 of 7,900 inhabitants fell ill with measles and 100 died. The second hypothesis is a lack of training of the innate immune system. So the trained innate immunity offers a partial cross protection against unrelated pathogens, and this has an overlap with a hygiene hypothesis where exposure to dirt is beneficial. Hypothesis 3 is that COVID-19 itself induces immune dysregulation. Some other viruses are known to cause this, and some countries had very little measures and still had big RSV surges, and some measured immune parameters are different after COVID-19. So this is an interesting slide here. I attended a talk at the ESCMID Global Conference in Barcelona 2024, where this researcher from the Netherlands, Professor Netia, gave a fascinating talk saying that epigenetic reprogramming of myeloid cells can lead to a faster and more effective innate immune response against unrelated pathogens. This slide here discusses examples of papers discussing long COVID and immune dysregulation. And this slide here shows you that severe COVID-19 can reprogram hematopoietic cells and establish an epigenetic memory for up to 1 year. And these alterations can affect the post-infection immune responses and controlled in part by interleukin-6 during acute disease, meaning that COVID-19 may leave a lasting for about 1 year or more immune dysregulation after its infection. So there are a few other competing hypotheses. Hypothesis 4 could be virus interference with COVID. So the viruses interfere with each other. COVID was the dominant circulating virus early in the pandemic, but this may explain the downturn, but not the irregular return of the other pathogens. Hypothesis 5 is psychological factors. So before the pandemic, people ignored trivial infections, but now they seek diagnosis more for infections, and this may explain the increased numbers, but not, for example, severe infections that occurred. And hypothesis 6 is a multifactorial causation with a complex interplay, which is not yet fully understood. So I'll jump to the conclusions. Many pathogens disappeared during pandemic restrictions and are now reappearing. Pathogens' absence is an unusual state and not their presence. COVID-19 pandemic created a human experiment unprecedented in history, and the pathogen return is part of the return to normality. But the reappearance is not homogeneous, and we see irregular and out-of-season return of pathogens after a pandemic bottleneck. We also seem to see more serious presentations, for example, in younger children, and an older than usual age at presentation. Which one of the hypotheses exactly applies is unclear to me. There is a likely combination of factors, for example, multifactorial, and the situation is quite complicated, and there's a need for ongoing research and observations. And this leads me to conclude my presentation and thank some of our laboratory staff and collaborators and the audience for their attention. Thank you again.
Thank you, Dr. Maiwald. That's a fascinating presentation, following up and going in more detail to information I've seen you present before on the calls with the Health Watch group. Would you say the overall load of respiratory infections or the overall burden, morbidity is about what it was before COVID now, or is it less, or is it more? When you put it all together, what's your perception?
My perception is that it is returning to roughly where it was, although it is still somewhere maybe a little bit above what we used to see before the pandemic.
Thank you.